Good afternoon. Welcome everybody to the Acute Flaximyelitis Working Group. This is a special podcast focused on poliomyelitis, what to do and how to manage suspected cases. This is a podcast that is being generated after the recent report of a case of poliomyelitis in the United States. The importance of this case report is because we have been focused mostly in acute flaximyelitis, and we have discussed extensively about the evaluation, management, and care of patients with acute flaximyelitis. And obviously, potential case of poliomyelitis are embedded in the evaluation of patients with acute flaximyelitis. The importance of polio actually is magnified by the fact that we believe that polio has been eradicated in the United States and many other areas of the world. But it's important to remind the audience that there are still cases of polio around the world, particularly in countries like Africa, where there are suspected cases of polio that have been associated with viruses that have been evolving from oral vaccination, and other countries, particularly Afghanistan and Pakistan, where there is still indigenous cases of polio. And the most important concern is that despite we have polio vaccines since the early 60s, the coverage of polio vaccines is not necessarily close to 100% around the world. We have a coverage with the polio, the OPV 80%, and around the world, we have inactivated polio-containing vaccine, the first dose, 79% of the population around the world up to 2021. And based on data from the CDC, the coverage with inactivated polio vaccine in the United States is close to 91%. So for this panel discussion, I have a great honor to have colleagues from the acute flaximyelitis group and the CDC, Dr. Kiran Thakur, who is at University of Columbia in New York, Sarah Kitts, the CDC, Dr. Matt Vogt, UNC, University of North Carolina, and Dr. Grace Gombolay at Emory University. Dr. Thakur is an adult neurologist who has extensive work not only in infectious diseases, but also epidemiological studies and global neurology. Dr. Kitts is an expert and has been one of the leading researchers at the CDC of cases of acute flaximyelitis, and she leads the CDC group on this effort. Dr. Vogt is a pediatric infectious disease specialist. He is not only a clinician, but he's also a scientist and has been involved extensively in analysis of enteroviruses and generation of new therapies for enteroviruses, including antibody treatments. And Dr. Gombolay is a pediatric neurologist who is working at Emory University in neuroimmunology, but she's also working extensively on acute flaximyelitis and the surveillance of acute flaximyelitis. So with this background and with this introduction, I'd like to start discussing about the topic of poliomyelitis. And I will start just with Sarah. Sarah, can you tell us about the polio case that was described in the United States?
Thanks, Carlos, and thanks for hosting us in this forum. So this polio case was identified in an unvaccinated adult who lives in Rockland County in New York. And this person presented to the emergency department with the acute onset of lower extremity weakness. And as part of that evaluation, had stool testing performed first for enteroviruses, and which includes testing for polioviruses. So the results of those poliovirus testing, first at Wadsworth, which is the New York State Public Health Lab, and then confirmed at CDC also, those stool results were positive for poliovirus. And so this is the first case of paralytic polio in the United States since 2013. I can also share, sorry, a little bit more information that the sequencing, so all polioviruses that are isolated are sequenced, and we do know that it shows that this virus was a revertant polio Sabin type 2 virus. So that is a vaccine-derived poliovirus type 2, which indicates that this transmission originated from somebody who received the Sabin oral polio vaccine type 2, most likely within the last year or so. And because OPV is no longer given in the United States, this suggests that the origin was somewhere outside of the United States in a country that had recently used OPV type 2. Right now, there are no other cases identified to answer that question.
Thank you, Sarah. That is very helpful. Matt, as a pediatric disease specialist that you are, what is the significance and implication of a case of polio in the United States?
You know, it's funny because when I saw that you were going to ask this question, a lot of thoughts came to mind. So I made myself pick one, and that centers around vaccination. Especially as an ID doc, you know, we have been hearing that ever since the pandemic started, and over 2 years from now, you know, is when we first all started sort of isolating and sort of disrupting our normal daily activities. One of the things that got disrupted for a lot of families was getting their children into their sort of typical normal primary vaccine series, which for reference, the poliovirus vaccine is absolutely one of those first set of vaccines that all children should be getting. So it just was a very sharp reminder to me that, you know, we need to make sure we're trying to get all vaccination back up to snuff, and any families who, you know, out of no fault of their own, weren't able to get to their pediatrician and weren't able to get their children those initial vaccines. Polio definitely part of that series, but all of them are very important as well.
Thank you, Matt. Grace, as a pediatric neurologist, what are the concerns that you may have about emergence of polio in the United States?
Yes, I have a lot of concerns about polio, especially with the neurological manifestations that patients can have, because a lot of patients can develop paralysis that it can become permanent, or they can even die from this disease. And the other thing that we know is that even when children have some sort of infectious encephalitis, even if they seem to fully recover, they definitely have some residual attention problems or cognitive difficulty later on. And I think the other concern we have to think about even long term is a post-polio syndrome, right? So there are some children who seem to recover from an acute polio infection and do well, but then many years later, even up to 40 years, without evidence of another infection, they'll develop new muscle pain, new weakness, they'll become very disabled from the post-polio syndrome. And so there's a lot of concerns about polio and the permanent disability and death that it can cause.
Thank you, Grace. Kiran, you are the adult neurologist in the group, and you are working in a major center in New York. And what are the implications of this reported case of poliomyelitis in your practice? Do we need to be concerned? Do pediatricians, neurologists, and other specialists need to be concerned about possible cases of poliomyelitis emerging in our practice?
Thanks for that question. I think to reiterate what Dr. Kidd mentioned, you know, I think there's been a huge effort by the local public health institutions that we have, the New York City, New York State Health Department, the Rockland County Health Department, the Center for Disease Control, to rapidly identify this case and to try our best efforts to work with community members to vaccinate and identify any at-risk individuals. So I think there's really good news that this is an isolated case. So, you know, I think that we have to emphasize that this is, you know, an incredibly rare condition. The majority of individuals are vaccinated for polio in early childhood. There's kind of large overall community vaccination efforts across regions of New York and New York City, as well as the United States. But I think we all need to kind of be aware, especially for us as neurologists, that in the differential diagnosis, you know, we've focused so much as a group on non-polio enteroviruses that we need to keep in mind, you know, obtain a vaccine history, which I know our pediatric colleagues are very used to doing. In adults, you know, that's something that we really need to emphasize, obtaining the local epidemiological risks of our populations. vaccine so that we can identify any potential holes that exist and then test rapidly, identify public health organizations rapidly so we can make our best efforts to ensure that this is, an N of 1.
Thank you very much, Kiran. So let's go to the basics. We have a young adult who was reportedly unvaccinated who developed poliomyelitis. And obviously, this is a preventable disease. So Matt, please remind us about vaccination for polio, the type of vaccines used in the United States and around the world, and what are the differences? I like to understand that concept because it's extremely important for explaining to the families and patients.
Sure. So just a little bit of history lesson that I think is the easiest way for me to go over a lot of this. There's really two main varieties of poliovirus vaccine. So the first one that really hit widespread use in kind of the early mid 1950s is the IPV vaccine. So you'll often hear IPV or OPV. So this first one that was available is IPV, which stands for inactivated poliovirus vaccine, or actually really poliomyelitis vaccine. This will often be called the Salk vaccine, which is Jonas Salk is the person who sort of championed the development of this vaccine. And as a little cheat for those who like to have ways to remember these things, Salk ends with a K, and this is a killed vaccine. So they take live poliovirus, they then use formalin and a chemical that inactivates. And so there's the word inactivated, or the I in the IPV. So you have inactivated virus that is then injected into the muscles, just like so many of our other vaccines. And then that leads to an antibody response that's protective against paralysis after poliovirus infection. About 10 years or so after that, so now in the early 1960s, the oral poliovirus vaccine, or OPV, came into use. And this is a live attenuated virus vaccine. This will often be called the Sabin vaccine. I think Dr. Kidd used that word before because Albert Sabin is the person who sort of championed the efforts to develop this technology. This does have live virus, but it has been weakened. So the virus vaccine strains do not cause paralysis, but they do replicate in your intestines and your gut, which is the same place that poliovirus enters the body and replicates. And just the replication of the vaccine strain is enough to elicit a nice antibody response, both in the gut mucosa, so the linings of your intestines, as well as in your circulation. Also very, very highly protective against paralysis. So both of these vaccines are incredibly, incredibly effective at preventing against paralysis after poliovirus infection. Now, the differences between the two vaccines, which there are some advantages and disadvantages to these differences, at least theoretically, because the oral poliovirus vaccine does have replicating attenuated virus, as we kind of already touched on, sometimes that vaccine strain can revert to a more neurovirulent strain. Now, that may be a problem for the person who receives the vaccine, causing them to be paralyzed, but oftentimes not. Oftentimes it actually can be a secondary person. So for example, in this case that we discussed that's from New York, this was an unvaccinated individual. So they did not take the vaccine into their mouth, and the vaccine itself, the revertant vaccine strain came from another individual. And that's because these vaccines can be shed in the stool for a period of weeks typically. But the advantages of the oral poliovirus vaccine is you get a much better gut immunity. So neither of these vaccines is perfect at preventing infection with the poliovirus, but the OPV, the oral poliovirus vaccine, is much better at that. And so when given on a population scale, the OPV vaccine is very, very good at also helping to eliminate circulation of wild-type poliovirus within a population. So that's what's helped us really get super, super close to eradicating the virus, from the face of the earth. In fact, there are 3 poliovirus types, and we've actually only got one of those types, the poliovirus type 1, still circulating in its wild-type form on Earth.
Thank you, Matt. That's a great explanation. Sarah, Matt, describe for us the way we vaccinate in the United States with IPV. However, other countries near to us, countries in South America, Central America, use OPV or combination of OPV and IPV. So please explain to us what are the implications of the different approaches and how the Center for Disease Control and Prevention, the CDC, works around the United States for detection of circulating polio viruses and detection of potential cases.
Thanks, and thanks to Matt for that explanation of OPV versus IPV. I'll try not to rehash that, but I want to reiterate that both vaccines are extremely effective at preventing paralysis due to poliovirus. So in the United States and globally, really, the polio surveillance really focuses on surveillance for the clinical syndrome of acute flaccid paralysis. And in the United States, that surveillance overlaps with our surveillance for acute flaccid myelitis. So in the US, we conduct surveillance and collect case reports for this clinical syndrome, and then test stool samples from patients with this syndrome in order to rule out poliovirus infection. So our main surveillance for poliovirus is via the clinical syndrome of paralytic polio. And that would not be expected to be affected by someone who had received OPV or IPV, right? So everybody prior, or most US persons who received polio vaccine prior to 2000 received probably at least one dose of OPV. And in fact, this surveillance system was how this New York case was identified. This was, an suspected or AFM case who had stool samples sent as part of that evaluation, and that's how poliovirus was detected. So I think the other type of surveillance that's possible and is sometimes done is environmental surveillance, which involves testing sewage or wastewater or other environmental samples for the presence of poliovirus. And this has been done for a while in countries where poliovirus is known to be circulating and there's vaccination campaigns, et cetera. But also recently, as during the pandemic, as wastewater surveillance for SARS-CoV-2 virus became more common, I think some countries have also started surveillance for other pathogens in wastewater, including poliovirus. And you might have heard about the recent detection in London wastewater of poliovirus that was not associated with a patient with any symptoms, but they had detected it in wastewater. So prior to this New York case, we had actually in the US had been discussing piloting, environmental surveillance or wastewater surveillance in the United States in several sites. And so definitely as part of the investigation of this case, we're looking at wastewater samples to try and understand where this originated. But that's something that I think to watch this space that might, as we develop a plan in the United States going forward for how we're going to use wastewater surveillance.
Thank you so much, Sarah. So Grace, the COVID-19 pandemic has produced an important reduction in the percentage of children that should be receiving the standard vaccination, including polio and measles. As a pediatric neurologist, are you concerned about reemergence of cases of poliomyelitis among children? And if we are, so what are the signs of alarm that will trigger the clinical concern for presence of polio?
Yeah, I think those are really important questions for us to consider. And I think what the group has already talked about, I think this case really emphasizes the importance of vaccination, whether it's for polio or for other infections. For signs of when you should be concerned about a polio infection, a lot of patients can present differently. Some of them can have just mainly flu-like symptoms. So the usual fevers, headaches, fatigue, muscle aches, that sort of thing. Some of them can have neck pain or stiffness or something that can look like maybe like a meningoencephalitis. The times that, would be really concerned about, especially as neurologists, would be those who develop acute flaccid paralysis, which people have alluded to already. And that can involve in the arms or legs or both. And this can occur over hours to even a couple of days. And then absence of reflexes can also be discovered on exam. And so I think sometimes this can be mistaken for Guillain-Barré syndrome. And then we've also talked about acute flaccid myelitis, which can present similarly.
Thank you so much, Grace. So Matt, Grace just mentioned acute flaccid paralysis and acute flaccid myelitis. So what are the differences between poliomyelitis and acute flaccid myelitis?
I think a lot of this comes down to semantics and how we use our words. So acute flaccid paralysis or acute flaccid myelitis, those are descriptions of clinical syndromes. So a patient walks in and has a very rapid onset of, with flaccid, meaning weakness, and paralysis, meaning obviously they can't use the muscles, and myelitis, meaning inflammation of the spinal cord. So really that same syndrome, but you have evidence of actually inflammation in the spinal cord. So those are sort of bigger umbrella terms. And, poliomyelitis really falls under those umbrellas. So poliomyelitis is just that same clinical syndrome, but very specifically due to the polio virus. So that's kind of how I would differentiate those terms. What we think of, though, oftentimes when we say AFM is sort of outbreaks of acute flaccid myelitis that we've had in the United States. I think that's probably what a lot of people really spring to mind when they hear that term. So we had outbreaks in 2014, 2016, and 2018, where we had a lot of these cases of AFM. And those outbreaks were chiefly driven by a virus called enterovirus D68, or we often will say EVD68. There was also contributions from another virus called enterovirus A71 in a much smaller amount. But it really turns out there's a lot of different viruses, especially within this enterovirus family, but in other virus families that can all cause AFM. So there's lots of different viruses that can cause this. And if it's caused by the poliovirus, it's poliomyelitis. The sort of main implications for that are really on a population level. So, again, if there's a big outbreak caused by enterovirus D68, well, that's caused by this virus that's more like a respiratory pathogen. So enterovirus D68, while a close relative to the poliovirus, they're in the same genus of viruses, really behaves more like the rhinoviruses, which are also in that genus. It's, causes a respiratory tract disease. The respiratory tract is the site where the virus gets in, as opposed to what I mentioned earlier about the poliovirus really gets in more typically through your GI tract or your intestinal tract. So sort of the main implications are how those viruses are spread. They're spread a little bit differently. And then also, I would say like the rate of paralysis after infection, which really appears to be much higher with poliovirus than with enterovirus D68. I say that with a little bit of trepidation because it's really hard to say what percentage of patients who get infected with enterovirus D68 get paralyzed, because it's really hard to put a denominator there to say how many total enterovirus D68 infections happen. I would say we really don't have a handle on that, but it seems to be a whole heck of a lot of enterovirus D68 infection with a relatively small amount of paralysis, as compared to what we have been able to define pretty well with poliovirus historically, which is about 1% or half to 1%, somewhere in that sort of very single digit or below single digit percent of poliovirus infections will result in paralysis. So while we have a lot less poliovirus circulating in the world, in fact, almost very, very, very little of it, the chance of getting paralyzed after that virus infection is higher, at least seemingly, than after an enterovirus D68 infection.
Thank you, Matt. It's very fascinating and particularly understanding the role of those viruses. Kiran, going back to the New York case, the patient was a young adult, and as clinicians dealing with adults, do we need to be concerned about polio, and when do we need to be concerned?
Yeah, so, I think to kind of the points that have been already stated, I think we need to be really cognizant of particular risk factors. As stated, this individual was unvaccinated, so certainly that was a risk factor here, as well as exposure risk. And so I think that, I think astute clinicians, this should definitely be on our radar. And I think traditionally, probably we've put poliomyelitis a little bit further back, but has implications, I think, not just for, differential diagnosis, but also for isolation precautions, hospital-related epidemiology that we have to think about. And so thinking about it early on and communicating with our ID specialists is really, really vital so that we're able to safely provide care to the patient, provide safety to the healthcare providers, provide safety to the community. So I think it should definitely be on our radar. I think traditionally, as an adult neurologist, we think of this clinical picture very much consistent with kind of a Guillain-Barré syndrome. There's certain clinical features, kind of the early onset after a viral prodromal illness, associated neck stiffness and fevers. we use that CSF as a branching point. So a CSF pleocytosis without elevated protein. So the opposite of what we kind of think of with traditional GBS is something that should really alert clinicians that there's something else going on. Certainly autonomic symptoms can be seen in both. Urinary and bowel symptoms can be pronounced in AFM. And I agree completely with Matt that these semantics, I think a polio kind of under the umbrella of AFM alongside other causes. We think, as you know, Carlos, you taught me to think neuroanatomically. So this is affecting the anterior horns of the spinal cord like other infections do, which is different from something like a Guillain-Barré syndrome, which affects the peripheral nerves. And so looks a little bit different clinically because of that, but can be very hard to distinguish early on. And so some of these features can help clinicians on the ground.
Thank you, Kiran. Matt, so Kiran called you. Kiran mentioned the importance of communication between the clinician taking care of the patient and the infectious disease specialist. So as a pediatric infectious disease specialist, what would you advise the clinical team? What to pay attention? What are the biological samples that need to be collected? What are the precautions that need to be taken care at the beginning?
Well, luckily, we have absolutely fantastic resources. You are not alone if you are ever in this scenario as a provider who is thinking about acute flaccid myelitis or poliomyelitis or whatever in any of these scenarios. Actually, the CDC, to toot Dr. Kidd's organization, to toot their horn a little bit, has wonderful resources around this. And it would be my first go-to place. And in fact, is my first go-to place if people ever call me and ask me these same questions. So I did this exercise before the podcast so I could tell people exactly what I did. And it's really the easiest way for me to remember, rather than remembering a specific URL, is what do I pop in Google? So if you are ever thinking that you might have a patient with acute flaccid myelitis, please just do these very simple steps and you will get everything you need, and you'll get it quickly and in a way that'll be the most helpful to both the patient and to everybody else on a sort of public health way. So the steps that I would do, I would go to my Google page and I would just do AFM CDC. That's it, because you're already thinking about AFM and you want the CDC webpage. So I think that's pretty easy for everybody to remember. Google AFM CDC, that'll bring up the CDC's acute flaccid myelitis webpage. If you scroll down ever so slightly, there's a box that says references and resources, which is why you're there. And then as you click that, it breaks it out for like different groups. And so there's a for clinicians group, which, I'm directing this to clinicians, obviously. And there's a nice little one-page PDF that you'll find there. It says job aid for clinicians. And it spells out exactly what are the types of specimens you want to get and how do you collect them and what do you do with them? And so as I teased earlier, the main viruses that we think about actually come in different varieties and they infect different, parts of the body as their primary spot of infection. And since when a patient comes in with this syndrome, we don't know, just by looking at the patient, you have no idea what caused this, whether it would be poliovirus or enterovirus D68 or something that's not a virus. And it's actually Guillain-Barré, it turns out. When they very, very first come in, typically AFM is part of a larger differential diagnosis, exactly what Kiran just said before. So the sooner you collect all these samples, the more likely are you going to be able to find a virus if it's one of these viruses that we're talking about. So you're going to want to collect, and you don't have to remember this anymore because now I've gave you the tools. You can just go to the PDF and it's on the PDF. But just to quickly review what it is, you're going to want nasal swabs to collect for any of these respiratory pathogens. That's especially going to be enterovirus D68 in this case. You're going to want to collect either stool or a rectal swab. That's a lot of the other enteroviruses, especially poliovirus. Those are very easily detected in the stool. And then we also want spinal fluid and blood, because we can also detect enteroviruses and sequence them in those places as well in people with these infections. So that's on that kit. And to put in another quick plug, if you do all those same things I just told you, and you get to that section and there's that one-page PDF on, what to collect and how to collect it, there is also a link to the AAP, the American Academy of Pediatrics, teamed up with the CDC to make a little series of quick videos around acute flaccid myelitis. These are freely available. You do have to sign up for this AAP PediaLink course thing. It is free, but you kind of have to go through the sign up process. So it's a little cumbersome. But there's about 6 15-minute videos about AFM And I did make the video on this topic of how to, why do we care about these specimens and what's the importance of them. So if you want a bit more on that, you can get that free video. There's also handouts and that AAP Pedia link, all these courses, each one has a bit of a handout as well. So that's another resource that's there, but really can't plug the AFM CDC website enough. I have found it very helpful, both in my academic life and in my clinical life. And I go there frequently.
And I'll just add, that's exactly how I get to those web pages.
Okay.
I Google
Yeah.
AFM, CDC, and then frequently I'll do another word depending on what I'm looking for. Surveillance will get you to a chart with the surveillance cases, and clinician or clinical guidance will get you to different pages. Yeah, so that's how I use it too.
Great. That's a very good point. And actually, I'd like to intervene here a little bit, because as neurologists, we frequently go for where the money is in the spinal fluid, and just a note of advice. So it's sometimes very difficult to isolate viruses directly from the spinal fluid. So that's the reason Matt emphasized on nasal swab and stool samples, because those are easy sources of isolating these viruses. Sarah, so now Matt explained about the guidance by the CDC, but for family members and for healthcare providers, tell us about the guidance from the CDC about precautions. So let's say we have a suspected case of acute flacimyelitis, possibly polio, or even enterovirus D68. Are the family members need to be concerned about any contamination or anything like that?
I think we're talking about two slightly different scenarios with enteroviruses, and poliovirus is definitely a little more of a concern. Certainly any patient where, enterovirus, AFM, or polio is being considered, contact precautions in the hospital is definitely recommended. But in terms of risk to contacts, and I guess that applies to both enteroviruses as a whole and poliovirus. But in terms of poliovirus and contacts, I mean, we can't emphasize enough, it's been emphasized already, that unvaccinated close contacts to the patient are at highest risk, right? So again, it's just urging healthcare providers to make sure their own vaccines are up to date, they've been vaccinated, that their patients are up to date on polio vaccine, and especially for patients who travel or are exposed to international visitors. And then, of course, we want to make sure, every effort to vaccinate eligible persons in the communities at risk. In terms of enteroviruses as a whole, EVD68, I don't think we know so much about who is susceptible and who isn't. As Dr. Vogt mentioned earlier, we think EVD68 is a very common infection and most people have already been infected. However, I would still treat that person as possibly infectious, and that's a respiratory virus. So in the hospital, I think contact precautions, I think masks are still in use in hospitals. I think all of those would be appropriate for AFM or polio patients.
Thank you so much, Sarah. Grace, in suspected cases that have acute flacimyelitis, either polio or AFM, what are the basic recommendations for acute clinical management?
Yeah, I think this is really important. And one of the references I'm going to point to is the recent review that was published in Lancet in 2021 from the acute flacimyelitis working group that Carlos, that you really led. And it gives you a lot of guidance of just basic background around AFM and the different management procedures that you should look for. And so just really briefly, a few things. Just like with every other patient, a really good clinical history and exam is important. If you have infectious disease and neurology consultants at your institution, definitely get them on board. Everyone should get an MRI brain and full spine with and without contrast, so you can really see whether or not there's infection or inflammation there. And then collecting the laboratory specimens like we talked about earlier, including the spinal fluid. There's some other mimickers that we haven't really touched upon yet. So for example, sending serum antibodies to aquaporin 4 and to the myelin oligodendrocyte glycoprotein, or MOG, because that's related to anti-MOG associated disorders, because sometimes those can also present with weakness and paralysis and or spinal cord changes that predominantly affect the gray matter, but it turns out to be aquaporin-4 or a MOG antibody disorder. And the reason why I emphasize the serum is because a lot of clinicians will send it in the spinal fluid because we're taught spinal fluid is more sensitive for neuronal antibodies, but aquaporin-4 and MOG happen to be those exceptions where serum's more sensitive. So definitely send both. And then you can consider other infectious studies, including like West Nile virus can also look like this too. And in terms of management, supportive management is really key, right? So a lot of these patients, especially if they have higher cervical spine involvement, they can have a lot of respiratory compromise. They can have autonomous dysfunction. So some of them may need to be admitted to the ICU. Some of them can have urinary retention, so need to monitor for that. And then pain can be a huge component, and especially for patients who are sedated, or when I think about our younger children who are not able to express pain with words, they may express it in other ways. Definitely trying to monitor that and keep on top of those symptoms is really important.
Thanks so much, Grace. Kiran, coming back to young adults, unvaccinated or immunosuppressed young adults, what are the recommendations for acute management? What is the evidence in favor of using steroid treatment or IVIG or any sort of treatment?
Yeah, I think, anecdotally, a lot of us use IVIG to kind of boost humoral immunity, and based on mouse models showed maybe some efficacy, but really in human studies has not panned out, although there's been a lack of overall kind of larger based studies to show whether there's, truly any efficacy. And, for other mimickers, certainly like my colleague saying we would use those agents, IVIG. Sometimes if there's a profound cord edema, especially in somebody who has, already had spinal stenosis, spine disease, and there's just a lack of space around the spinal cord, certainly my preference would be to give steroids. The risk of that is that you have an active infection somewhere. And so we, have to be really careful with that. But it's, I would say, I think a case-by-case basis with a lack of evidence. A lot of what we do in neuro-ID and neuroimmunology, it's not evidence-based. It's more based on clinical acumen. So, if someone is weeks out from a febrile illness, they have lots of cord edema, they have anterior horn cell gray matter involvement, I would feel more comfortable doing that. Certainly, in the case of polio, oftentimes the febrile illness and meningitic symptoms are really closely in parallel with the development of the acute flaccid paralysis. And certainly there's a lack of evidence overall of using those agents for polio.
Thanks so much, Kiran. Matt, do you like to add anything about treatments, any possible future therapies that you may think may come very soon?
I think others have made the comment, when you have neurology specialists available, please talk to them. As the ID guy, when it comes to real humans in the clinic, that's how I feel. And that's what I recommend to others. But I am, as you mentioned, also a basic scientist. And so we do a lot of work on trying to understand how this disease works in the lab and ways we can hopefully, avert it or at least abort it wherever it is when we find the patient. And Dr. Thakur alluded to some data in mice. We have also some data in mice to show that not only if you give IVIG, which is, you'll remember, right, polyclonal, lots of antibodies against lots of things, which includes enterovirus D68. So actually there's some nice work that's shown that pretty much every lot of IVIG that's out there has a decent amount of enterovirus D68 antibodies, neutralizing antibodies in those lots. We've generated some human monoclonal antibodies from people who had EVD68 infection, and at least in the lab in a mouse, which is not in a human, we've seen some encouraging data that at least there is a window of opportunity in which there is time to give these antibody treatments and potentially, at least again, sort of stymie the progression to more illness. And I know of some other labs that have been out giving talks furthering these studies. Ken Tyler's lab at the University of Colorado, I think, to tease them, there should be a publication coming out sometime in the near future where they show even more, I would say, further encouraging data that antibody therapeutics could be helpful. We have been partnering with some companies to try to get these into humans. So we do have, lots of antibody that have been made under GMP conditions, which is what you need to do to actually put things into humans. And we're working with the FDA, we're working with the NIH to get, funding and regulation and things approved. But also, as has been mentioned by others, it's really hard to study these rare diseases. Obviously, if it happens to you or someone you know and love, it's not rare, it's real and in front of you. But on a population level, to do studies where you can really prove efficacy is very hard. So, we have to rely on these either animal studies or we just published, it was a case report of a single patient who had AFM where it was a human. So actually, which was nice, not a mouse, but a human, and really saw somewhat early in disease, about 5 days into this patient's, 3 days into their weakness, 5 days into their sort of fever and respiratory illness, really good evidence that the virus is absolutely in the neurons, replicating in those motor neurons in the anterior horns. So like you said, Kiran, it makes you really nervous about giving steroids when there's active virus replication in these neurons. But at the same time, we saw a lot of inflammatory cells around those neurons. We saw macrophages, we saw CD8 T cells, which their job is to kill infected cells. That's their job. So, probably my guess, based on all this evidence, would be that, we need some sort of antiviral types of therapies, whether those are small molecules or monoclonal antibodies or whatever, something to try to stymie the virus. But then, there may be a component of needing to modulate the immune response as well. So, I'm a huge proponent of IVIG because there's both neutralizing antibodies in the IVIG and there's immune modulating properties. So, I'm a huge fan of it for AFM, but it's relatively nonspecific. And, the data that we do have doesn't really support its efficacy, but it's also so hard to study these rare diseases. I don't think that means it's not efficacious. I just think it means we don't have data that shows it's efficacious.
Thank you, Matt. And perhaps as a good note is we already have a very good approach to deal with polio, yes, to get vaccinated everybody. And vaccination is key for everything. Sarah, any final comment and final thought about polio and awareness?
Yeah, I think this most recent case really highlights that we all live in a global society, right? And that if there's circulating virus anywhere, then for a vaccine preventable disease, and unvaccinated people anywhere are at risk. And so I think that the best way in terms of this country to keep United States polio free is to keep up those vaccination rates and have population immunity. So, assure everybody that that's the focus of this intervention public health response to this case, is to hold vaccination clinics and really try and get the message out about vaccinating people who are not completely vaccinated.
Thank you so much, Sarah. Grace, any final comment?
Yeah, I think this is just really highlighting what everyone has said, that we just really need to make sure that everyone's vaccinated. I think this is really helpful for clinicians just to be aware of and just thinking about polio, because I think a few people have talked about this. Poliomyelitis is not something that a lot of clinicians in the US think about just because we think it's eradicated. It's just making sure that we are aware and considering all those resources that are available for clinicians should you come with a patient who has acute flaccid paralysis.
Thank you, Grace. Kiran, your last thoughts?
Yeah, I think in addition to what everybody has emphasized, I think this really, we're speaking to healthcare providers. I think we're at the front line of serving public health, and to emphasize the importance of reporting to public health agencies early and rapidly. That's not so easy for busy clinicians. It takes time, effort, energy, sometimes a long process, but really so incredibly important, and is like a safety net to providing good clinical care. So I think that's really one of the lessons here, is just that relationship between the clinical practitioner and public health agencies, which, is really bidirectional.
Thank you so much. Matt, your final comments?
I think this just really highlights for me the value and efficacy of what's in place. I know these days, if you get on Twitter, which I don't necessarily advise anybody do that, but if you do get on Twitter, it's really popular sometimes to pile on groups like the CDC that serve public health, that often have the unenviable position of balancing, what's good for the individual versus the population. our AFM surveillance systems were in place. They captured this case. They found out that it was poliovirus very quickly, and they reacted very quickly. That's exactly what it's meant to happen. That it worked. And for the record, Sarah, I think the CDC is great. I don't like to pile on the CDC, but I want everybody to be reassured that this was the system working. And we all play a role in it, as Dr. Thakur just said, but do your part and it works, and it did. So good job. Hooray.
Thank you so much, Matt. And again, for the entire group, the acute flaccid myelitis working group is precisely a multidisciplinary group with the main concept to generate consensus and discussion about acute flaccid myelitis and disorders associated with acute flaccid myelitis, including polio. And again, for our panelists, I really appreciate very much your time and dedication. And thank you, Kiran. Thank you, Matt. Thank you, Grace. And thank you, Sarah, for participating in this panel and discussion. And I hope that we can continue working together and trying to motivate people to work about the concept of vaccination and improving the healthcare for patients with acute flaccid myelitis and other disorders. Thank you so much.
Thank you, Carlos.
Thank you.
Thank you.